Now it's my great pleasure to introduce Professor Ewa Jankowska from Wrocław. Ewa is a great expert of heart failure in general, has been part of the past two guidelines, and has been in the steering committee of many iron replacement studies. And she's also a great expert of iron deficiency. Please, Ewa, and we'll wait to learn more and more on iron deficiency with and without anemia.
Ladies and gentlemen, it's my great pleasure and honor to discuss with you the issue of iron deficiency in heart failure in patients with and without anemia. This is the conflict of interest from my side related to this presentation. Together with Piotr Bonikowski, we have then copy-eyes of the AFFIRM AHF trial. We have gathered quite substantial evidence demonstrating that iron deficiency is the most common non-cardiovascular comorbidity in patients with heart failure, reaching 70, even 80% of prevalence in patients after episode of acute heart failure. Iron deficiency, regardless of concomitant anemia, when present in patients with heart failure, translates into reduced exercise capacity, poor quality of life, high risk of recurrent heart failure hospitalization, high all-cause and cardiovascular mortality, as well as high healthcare costs. If we try to distinguish the effects on mortality, for example, between patients who are just anemic and those who are just iron deficient, it's easy to see when patients are iron deficient and anemic, the mortality is the highest. But if we compare those who are just anemic and those who are iron deficiency, we can see that high mortality is related with the presence of iron deficiency, not anemia itself. From the pathophysiological perspective, iron is involved in several hematopoietic pathways, contributing to the production of hemoglobin. But something which I think is much more important for patients with heart failure is involvement of iron in several non-hematopoietic pathways. Among them, the role of iron in mitochondria is critical. We know at the moment that iron deficiency translates into mitochondrial dysfunctions and abnormal energy metabolism, also within skeletal muscles and myocardium. And we think that this pathomechanism might be of particular importance for patients with heart failure. Already more than 10 years ago, a FARAGEF trial was published demonstrating for the first time that intravenous ferric carboxymaldose in patients with heart failure who are iron deficient can improve quality of life, exercise capacity, and can attenuate heart failure symptoms. And as you can see here, these effects are seen very, very early, already 4 weeks after the first dose has been administered. It's very interesting to look at the data from FARAGEF trial when patients were split into those who were and who were not anemic. These two groups received more or less the similar amount of intravenous ferric carboxymaldose. But as you can see here, patients who were anemic, hemoglobin went up. But in patients who were not anemic, even though they received similar amount of intravenous iron, hemoglobin did not change significantly. At the same time, both groups, patients who were and who were not anemic, improved clinically. In other words, we can say that intravenous iron supplementation in patients with heart failure who are not anemic benefit, and these benefits are seen beyond the effects on erythropoiesis. The next trial, AHF trial, confirmed to some extent the fact that ferric carboxymaldose can improve exercise capacity, as this treatment was related with the extension of 6-minute walking test distance. But importantly, among several secondary endpoints of this analysis, it was demonstrated that intravenous ferric carboxymaldose therapy translates into the reduction of risk of heart failure hospitalizations during 12-month follow-up. Importantly, please remember Based on iron out trial, we can say that oral iron therapy does not work in patients with heart failure. In this trial, oral iron therapy did not change peak oxygen consumption in patients with heart failure who are iron deficient. And it was because that during oral therapy, as you can see here, neither ferritin nor TSAT change. You can see, on the other hand, how huge increase was seen regarding serum ferritin and TSAT when patients receive intravenous ferricarboxymaltose. At the moment, we have clear evidence that intravenous iron can improve exercise capacity, quality of life, but until November 2020, we did not know whether this treatment can also improve clinical outcomes. At that time, last year, we published the AFFIRM-AHF trial. It was a trial performed in patients who were hospitalized due to acute heart failure, who were iron deficient, with ejection fraction below 50%. When patients were stabilized, were confirmed to be iron deficient, and were about to be discharged, they were randomized to either ferricarboxymaltose or placebo. These patients were treated for around 24 weeks and they were followed up to 52 weeks. The treatment was extremely simple. Patients received ferricarboxymaltose based on hemoglobin level and body weight. The major treatment was given at week 0 and 6, and majority, 80% of patients received only 2 doses of ferricarboxymaltose, and an average dose was around 1.4 gram of ferricarboxymaltose. Only few patients remained iron deficient at weeks 12 and 24, and they received additional ferricarboxymaltose dose. This is the population of the AFFIRM-AHF trial. Mean age was around 71 year, and ejection fraction was around 33%. Around 50% of patients had ischemic heart failure, and around 30% of patients had newly diagnosed heart failure. Here, I would like to focus your attention on the very high NT-proBNP. In both study arms, much more about 4,000. This is the highest NT-proBNP level ever reported in any clinical trial in patients with heart failure. And here, there are the major results of our trial. Ferricarboxymaltose resulted in trend towards the reduction in the primary endpoint, considered as the total heart failure hospitalizations and cardiovascular death, with P or with 0.059. And this effect was driven mainly by the significant reduction in the total heart failure hospitalizations with a p-value 0.013. Our study was hit by the COVID-19 pandemic, and in order to avoid any effect, any influence of this situation on the follow-up and the execution of the trial, we pre-planned pre-COVID sensitivity analysis. It means that during this analysis, the follow-up of the patients was censored at the date when the first COVID-19 case was diagnosed in every particular country. As you can see here, the results were virtually the same. Even the primary endpoint met statistical significance. The treatment was extremely safe. There was no sign of any risk related with this treatment. Also, there was no effect of ferricarboxymaltose on serum phosphate. As you can see here, no differences in serum phosphate between both study arms during the whole trial. In our study, we also confirmed that this treatment can improve quality of life. The effects were seen already after 4 weeks when the first dose was supplemented, and the effects were seen clearly until 24 weeks. The same was seen when we assessed the clinical summary score Kansas City Cardiomyopathy Questionnaire, which reflects only symptoms and functional limitations. We are also very tempted to see whether we can save money using this treatment. We performed cost-effectiveness analysis from the payer perspective in 4 countries, UK, US, Italy, and Switzerland. And in the model, we considered deaths, hospitalizations, and changes in quality of life. Without going into further delays, I would like to tell you that we have demonstrated that for US, UK, and Switzerland, pericarboxymaltose applied in patients after episode of acute heart failure in iron deficient patients was dominant. It means it was related with lower costs and higher effectiveness as compared to placebo. In Italy, it was highly cost effective. It means that the treatment was slightly higher regarding the cost, however, remained much more effective as compared to placebo. The effects were virtually the same when patients were split into different clinical subgroups. I think I have demonstrated here quite substantial and convincing evidence regarding the role of iron deficiency in heart failure and the role of intravenous iron supplementation. Surprisingly, you can see here, based on data from Germany, that only few patients, less than 2%, patients who are hospitalized are screened for iron deficiency. Among them, around 20% of them receive the proper therapy. So, in other words, we can say that this treatment requires more awareness. Based on evidence I have demonstrated, we formulated the ESC heart failure guidelines, where we included two recommendations. One relates to the fact that intravenous pericarboxymaltose should be considered in patients with iron deficiency in order to alleviate heart failure symptoms, improve exercise capacity and quality of life. And the new recommendation, another, which can indicate that intravenous pericarboxymaltose should be considered in patients with heart failure to reduce the risk of heart failure hospitalizations. Very important recommendation, already repeated the second time in the guidelines in the context of the peri-discharge care. So in conclusion, we can say that iron deficiency is very common in heart failure patients. It translates into poor outcomes, poor quality of life, but at the moment we have quite effective and safe treatment for these patients. The other story is how to change the situation that iron deficiency in heart failure is still underdiagnosed and undertreated. Thank you very much.
Thank you, Ewa. Very nice talk, as usual. We were discussing earlier with Gianluigi Savarese how frequently we should monitor kidney function. Now, what is your suggestion for iron deficiency? We know that the guidelines give some suggestions, but what is your practice in your clinic, in your everyday clinic?
Regarding kidney function?
No, regarding iron deficiency.
One very important comment. I think it also has been mentioned by Gianluigi and also during my talk. The problem is completely, I would say, even neglected, ignored, and people, I think our colleagues are not aware about, first of all, the high prevalence of iron deficiency in patients with heart failure, and also very importantly, people are not aware about huge benefits that patients with heart failure can get when intravenous iron is supplemented intravenously. This is extremely important comment. I also have been listening to your discussion regarding the anemia and iron deficiency, and I think it has to be extremely emphasized that we want to treat iron deficiency, not anemia per se. Something that have been observed in the our trials that we have been executing, that patients who are not anemic seem to benefit even better from intravenous iron supplementation. So something that we see that iron is needed, not just for increased hemoglobin level, but it has to be incorporated into heart and into skeletal muscles, and in this way improves the functioning of heart and skeletal muscles.
Can I ask a question regarding the trial? The grouping was 8 to 14, 14 to less than 15, and then 15 and above. I mean, why the range is so wide from 8 to 14, the hemoglobin? I mean, this is so wide, and then you narrow the scale and then narrow it again. So this can affect the result of the trial?
The concept that we have when we are designing the AFFIRM-HF was to have as much as possible the population that would reflect clinical practice. Something that we couldn't do, we couldn't give iron to patients who have too high hemoglobin, but too high hemoglobin, it means hemoglobin above 15. That's why the upper range was 15. But what we believe that patients who are who have either low hemoglobin level or have normal hemoglobin level, they also benefit from intravenous iron supplementation. And as you could see also from the AFFIRM-HF trial, we did the subgroup analysis, splitting patients based on low and normal hemoglobin level. And you can see that the benefits were seen in both groups. However, even in patients who have rather higher hemoglobin level, these patients benefited with a greater extent. I think we have quite confirmed evidence that we want to treat iron deficiency rather than anemia.
I think that's very important. Answer our question before about the iron deficiency rather than anemia. Yeah, as I was saying before, actually, during the symposium, that, you know, this is really eye-opening because we are really rarely looking at that, and it actually improved a lot of quality of life of our patients by. So my question maybe not to heart failure. Does this medication we have now for heart failure or iron deficiency, can we use it for iron deficiency without heart failure, or no?
Data that we have at the moment, we have quite good evidence regarding using this drug in patients with chronic kidney disease. This is very, very commonly used. We have some trials which confirm safety and efficacy. And also we have, let's say, less established evidence, but still for pregnant women, for children, and also for the elderly. However, I have to say that the trials that we have in heart failure are the only trials with intravenous iron which have tackled the problem of morbidity and mortality. So we have huge advantage. But on the other hand, we have to take in advance that the population that we have been studying, this is population of the very high risk. So if we show the safety in such a high risk population, it seems that this drug has quite high potential for efficacy and also for safety.
Thank you very much. Now it's time